Welcome to the Deep Dive. Today, we're really getting into a topic that touches so many lives, but is often surrounded by misunderstanding eating disorders.
That's right.
We're going to unpack the insights from N126, Chapter 14, Eating Disorders by Lorraine Chiappetta. Our goal, to give you a clearer, more empathetic view, moving past the headlines to, well, the science and the human side of things.
Absolutely. And this source is so important because it gets right to the point. These aren't just about food or wanting to be thin. There's serious disruptions in eating and how people see their bodies. They're recognized in the DSM-5.
The official manual for mental health conditions.
Exactly. And tragically, they have some of the highest mortality rates of any psychiatric illness. So we really need to understand what that means for people going through this.
Okay, so let's start there. To really understand, we need to know what we're talking about. This deep dive focuses on three main ones: anorexia nervosa, bulimia nervosa, and binge eating disorder. Can you help us sort of pin down the differences?
Yeah, that's key because they're distinct. Let's take anorexia nervosa, AN. The core feature is this intense, almost phobic fear of gaining weight.
Even if they're already underweight.
Especially then. There's a really distorted perception of their body shape and weight. It leads to self-starvation. And the source actually mentions two subtypes. One where people mainly restrict food, and another where they might binge and purge but still maintain that dangerously low weight.
Okay, so that's anorexia. How does bulimia nervosa differ? Because the name sounds similar in some ways.
Well, with bulimia nervosa, or BNA, you see recurrent episodes of binge eating. And we mean eating a significantly large amount of food in a short time, feeling out of control.
Right.
And then, crucially, they engage in inappropriate compensatory behaviors to try and prevent weight gain.
Like what kind of behavior?
Things like self-induced vomiting, misusing laxatives or diuretics, sometimes fasting excessively or exercising compulsively. It's a cycle of binging and then trying to undo it.
Got it. And the third one, binge eating disorder. How is that different from bulimia if it also involves binge eating?
Good question. Binge eating disorder, BED, shares that pattern of recurrent binge eating, often with feelings of distress, guilt, or shame afterwards. But here's the main difference. People with BED do not regularly use those compensatory behaviors like purging or excessive exercise.
Ah, okay.
And the source points out that because of this lack of compensation, BED often leads to obesity, although not always.
Looking at the bigger picture, the numbers, they're quite sobering, aren't they? Who is affected by this?
They really are. The data highlights a major public health issue. We're talking up to 30 million Americans affected by an eating disorder.
30 million, wow.
Yeah, and think about this. 1 in 5 women struggles with an eating disorder, or what we call disordered eating. And it's not just teenagers. Middle-aged women are actually the fastest growing group getting diagnosed.
That's surprising.
It is. And among adolescents, eating disorders are the third most common chronic illness. Looking at specific lifetime prevalence, it's about 0.6% for AN, 1.0% for BN, and 2.8% for BED.
And does it affect men and women equally?
Females are affected more often, more than twice as often overall. But, and this is important, around 10 to 15% of people with anorexia and bulimia are male. So it's definitely not exclusively a female issue.
With numbers like that, it can't be just one simple cause, right?
Yeah.
What does the source say about why these develop?
Not at all simple. The source really emphasizes this complex interplay. It seems to involve a sort of biological vulnerability that gets activated by a mix of genetic factors, psychosocial influences, and cultural pressures.
Okay, so let's break that down. Biological vulnerability.
Yeah, the source suggests that faulty neurobiology might actually be the most significant underlying factor, more so perhaps than the environmental things we see more easily.
What does that mean, faulty neurobiology?
Well, it points towards issues in the brain's reward system, maybe involving dopamine activity. Certain brain areas, like the orbitofrontal cortex and the insula, seem to function differently. And get this, malnutrition itself can actually cause changes in the brain, which can then perpetuate the disorder. It's kind of a vicious cycle.
So the body's response to starvation can worsen the brain issues?
Potentially, yes. And then there's genetics.
Right, you mentioned genetics.
Definitely a factor. If you have a first-degree female relative, like a mother or sister with AN or BN, your risk is higher. Children of someone with AN have about a 10-fold greater lifetime risk.
10 times, that's significant.
It is. And there are even specific genetic markers, like anomalies on chromosome 12 associated with AN. So there's a clear inherited piece to the puzzle.
Okay, so biology, genetics, what about the environment? the
Yeah.
psychosocial and cultural stuff.
Huge influences there, too. The source mentions things like difficult family dynamics, maybe poor ways of handling conflict, low satisfaction within the family. Trauma is a big one, too.
What kind of trauma?
Particularly childhood physical or sexual neglect seems closely linked. And then there are external pressures. Think about careers or sports where thinness is really emphasized or even required.
Like ballet dancers or runners.
Exactly. Female athletes in running, gymnastics, ballet are at higher risk. And for men, think about bodybuilding or wrestling. Also, culturally, these disorders are more common in industrialized societies where being thin is often seen as highly attractive.
Are there differences across ethnic groups?
Yes. The source notes that weights tend to be lower in young Latin American, Native American, and African American women compared to Caucasian women. But interestingly, it also mentions that African American women might be more likely to engage in purging behaviors if they do struggle.
So it manifests differently sometimes.
It can, and things like stressful life changes can act as triggers. But again, the source circles back to that underlying neurobiology potentially being the most weighty factor. Oh, and one more thing often. People who develop AN and BN showed certain traits before the disorder started.
Like what?
Things like being very anxious, obsessive, maybe perfectionistic, very achievement-focused. These traits might create a vulnerability.
Okay, so we have this complex picture of causes. Now let's talk about the impact. What does it actually look like for someone living with ANN or BN day to day, the clinical picture?
Well, for anorexia, beyond the weight loss, you see this absolute terror of gaining weight, a constant, overwhelming preoccupation with food, calories, dieting.
Even though they're restricting food.
Yes, it's paradoxical. They might hoard recipes, cook elaborate meals for others, but eat very little themselves. There's often peculiar handling of food, cutting it into tiny pieces, eating very slowly, and often rigorous, excessive exercise.
And that distorted self-perception you mentioned.
Critically important. They genuinely see themselves as overweight or fat, even when they are objectively dangerously thin, emaciated even. The source also highlights related cognitive distortions like unhealthy thinking patterns.
Can you give an example?
Sure, like all or nothing thinking. If I eat one cookie, I've blown my diet completely, so I might as well binge. Or catastrophizing, gaining a pound would be the end of the world. Or personalization, thinking everything is about them and their weight. These thoughts really fuel the disorder.
That sounds exhausting. And for bulimia, what are the signs there?
With bulimia, the central features are those cycles. The binge eating, often done in secret, feeling out of control, followed by the compensatory behaviors we talked about, vomiting, laxatives, etc.
Right.
It's interesting, the source notes that about a quarter to a third of individuals with BN actually have a history of AN. You also often see other issues alongside it.
Like what?
Depressive symptoms are common. Problems in relationships, struggles with self-concept, impulsivity in other areas too, maybe substance misuse. There's often a lot of anxiety and compulsivity wrapped up in it. The binging might even be an attempt to cope with feelings of emptiness or depression, a way to numb out perhaps.
The physical consequences must be severe for both. What does the source say about the medical complications?
Oh, they are severe and potentially life-threatening. For anorexia, the effects of starvation are systemic. The heart rate can slow dangerously, that's bradycardia. Blood pressure can drop. There are risks of serious electrolyte imbalances that can cause sudden cardiac arrest.
Just from the lack of nutrition.
Absolutely. Bones weaken, leading to osteoporosis. The body struggles to stay warm. You can get skin changes like yellowish skin from keratonemia or bluish hands and feet from poor circulation called acrocyanosis. Liver function can be affected. Hormone levels get disrupted, leading to things like missed periods in women. It's a multi-system breakdown.
That's terrifying. And bulimia, does the purging cause different problems?
Yes. While there's overlap, bulimia has its own set of serious medical risks, largely related to the purging. Like AN, the electrolyte imbalances from vomiting or laxative abuse are incredibly dangerous and can also lead to cardiac arrhythmias and sudden death. Dehydration is a constant issue. The stomach acid from repeated vomiting causes severe erosion of tooth enamel, sometimes even loss of the dental arch. Salivary glands can swell up, and there's a risk of tearing the esophagus that's a medical emergency. Plus, the source mentions Russell's sign.
What's that?
It's calluses or scarring on the knuckles from repeatedly inducing vomiting. It's a visible sign healthcare providers might look for.
The source uses the example of Tina, a 16-year-old, to really drive this home, doesn't it?
It does. She was at only 60% of her ideal body weight, described as cachectic, severely wasted away, hypotensive, dehydrated, with critically low potassium, experiencing heart rhythm problems. It's a stark reminder of just how physically devastating these illnesses are.
Okay, so given how serious this all is, assessment and treatment must be critical.
Hmm.
How do professionals even begin? How do they know what kind of care someone needs?
It's a crucial first step. There are screening tools, like the SKOF questionnaire. It asks simple questions about feeling sick because you're full, losing control over eating, losing more than 1 stone, about 14 pounds, thinking you're fat when others say you're thin, and food dominating your life.
Just a quick screen.
Exactly. Then the priority is assessment to figure out the level of care needed. Is outpatient treatment enough, or is hospitalization required?
What determines if someone needs to be hospitalized?
The source lays out specific criteria. Physically, things like extreme weight loss or rapid decline, severe hypothermia, a very low heart rate or blood pressure, or significant electrolyte disturbances would warrant hospitalization.
So immediate medical danger.
Right. And then there are psychiatric reasons, too, if someone is actively suicidal or self-harming, if they can't stop using substances alongside the eating disorder, if they're just not able to follow an outpatient plan, or if they have severe depression or psychosis, or even if there's a major family crisis preventing safe outpatient care.
Okay, so once the immediate crisis is managed, what does treatment generally involve?
It absolutely requires an interdisciplinary team. You can't tackle this from just one angle. You need primary care doctors, maybe medical specialists like cardiologists or gastroenterologists, nurses, psychologists, psychiatrists, registered dietitians or nutritionists, everyone working together.
And family involvement.
Very important, especially for adolescents, but really for anyone. Family psychoeducation helps everyone understand the illness and how to support recovery.
What are the main goals in the acute phase of treatment?
First, stabilize any immediate medical problems. Then, nutritional rehabilitation is key. For anorexia, that means carefully managed weight restoration. For bulimia, it's about stabilizing metabolism and stopping the binge purge cycle. And alongside that, you start working on modifying the distorted eating behaviors and challenging those deeply ingrained, unhealthy beliefs about weight and body image.
How do they do that?
It often involves structured meal plans, maybe supervised meals to reduce anxiety and ensure intake, regular weigh-ins, and lots of therapeutic support. Working closely with a nutritionist is vital.
And what about the psychological side? What kinds of therapy are used?
Psychotherapy is really the cornerstone. Cognitive behavioral therapy, CBT, is very common, aiming to change those negative thought patterns and behaviors. There's even an enhanced version, CBTE, specifically designed for eating disorders.
Okay.
Dialectical behavior therapy, or DBT, is also used particularly for bulimia and binge eating disorder because it helps with managing intense emotions and reducing impulsive behaviors like binging. Interpersonal psychotherapy, ITP, looks at relationship difficulties that might be contributing. There's also a mantra specifically for adults with ANN.
You mentioned family earlier. Is there a specific family therapy approach?
Yes, and it's a really important one. Maudsley therapy, also known as family-based therapy, or FBT, has the strongest evidence base, especially for children and adolescents with anorexia. It empowers the family to take charge of renourishing their child. It's also shown effectiveness for bulimia.
Lots of different therapeutic tools.
Absolutely. Group therapy can also be very helpful, providing peer support. Motivational approaches help engage patients who might be ambivalent about change.
Is medication usually involved?
It often plays a role, yeah, but usually not as the primary treatment for the eating disorder itself, more for managing co-occurring conditions or specific symptoms.
Like what?
For example, fluoxetine, which is an SSRI antidepressant, might be used for depression, or the obsessive-compulsive symptoms common in both AN and BN. It's actually shown to help reduce binging and purging in bulimia.
Any others?
Olanzapine, an atypical antipsychotic, is sometimes used in anorexia to help with weight gain and reduce some of the intense obsessive thoughts about food and weight. Topiramate, an anti-epileptic drug, has shown some promise for reducing binge urges in bulimia and obsessive behaviors in BAD. And lisdexamfetamine, a stimulant, is approved specifically for moderate to severe BED in adults.
It sounds like the connection between the caregiver and the patient is really important, too. The source mentioned Stacy's story.
Yes, that vignette really highlights the power of empathy. Allowing Stacy to express her fears and pain, understanding the immense pressure she felt from her family, that therapeutic relationship, that human connection, is crucial. It shows how effective care isn't just about protocols, it's about really seeing and hearing the person struggling.
Recovery sounds like it's often a long journey, not necessarily a quick fix. What does the source tell us about the long road, about prognosis and relapse?
You're right, it's definitely not usually a straight line. The source indicates that maybe about a third of patients recover fully, another third might improve but still retain some symptoms, sort of sub-threshold, and unfortunately about a third may struggle with a chronic form of the disorder long term.
Are the recovery rates different for EN and BN?
Yes, generally. For anorexia, recovery rates are estimated between 44% and 76%, but it often takes a long time. The source mentions an average of almost 5 years. Bulimia tends to have higher short-term recovery rates, maybe 50–70%, and generally a better overall prognosis than anorexia, but relapse is still a risk.
So what does long-term treatment look like to support people through that?
It's typically outpatient-based, continuing therapy and nutritional counseling as needed. The focus shifts to maintaining progress, managing triggers, continuing to work on the underlying psychological issues, and building skills for coping with life's stresses in healthier ways. It's about relapse prevention and sustaining recovery.
You mentioned cultural pressures earlier. How does something like social media fit into this long-term picture?
Social media, it's complicated. The source points to the existence of so-called pro-anorexia, and pro-bulimia websites and online communities.
What do they do?
They often present eating disorders not as illnesses, but as lifestyle choices. They might share tips for restricting or purging, post inspiration images, and really normalize and encourage these dangerous behaviors.
That sounds incredibly harmful.
It absolutely can be. But the source also notes a strange paradox for some individuals. These sites provide a sense of belonging and understanding, especially if they feel isolated in their real life.
So it meets a need, even if in a destructive way.
Kind of. The challenge for treatment providers, then, is helping people find genuinely supportive communities that promote health and recovery, not illness. And social media can be used positively. Reputable organizations like the National Eating Disorder Association, NED, have online resources. There are recovery-focused apps for self-monitoring and support.
So it's about navigating that online world carefully. What if someone struggles chronically, if full recovery seems out of reach?
For those with severe, enduring anorexia, the source mentions a harm reduction approach as a possibility.
Harm reduction, what does that mean in this context?
It means shifting the focus from complete abstinence from all symptoms, which might not be realistic for that individual, towards improving their quality of life and minimizing the physical and psychological damage. It's about managing symptoms to reduce harm, rather than aiming solely for a cure that hasn't been achievable.
That sounds like a pragmatic, compassionate approach for very difficult situations.
It can be. And underpinning all of this, whether aiming for full recovery or harm reduction, is the importance of the therapeutic relationship. The source emphasizes empathy, compassion, respect from caregivers. When patients feel truly heard and supported, when the approach is person-centered, their motivation to engage in treatment is so much higher.
So when we pull this all together, our deep dive really shows that eating disorders are far from being simple choices or phases. They're complex psychiatric illnesses with deep roots, biological, psychological, genetic, cultural.
Truly, exactly. They're serious, potentially fatal conditions.
And understanding the differences between anorexia, bulimia, and binge eating disorder, recognizing the severe medical risks, and knowing about the comprehensive, team-based approaches to treatment, that's all crucial for effective care, and frankly, for just having more compassion.
It really is. Which kind of leads to a final thought, perhaps for you, our listener. We've talked a lot about the intense societal and cultural pressures around body image. So maybe the question to ponder is, how can we, in our own lives, in our communities, start fostering environments that genuinely value health in all its diverse shapes and sizes, instead of reinforcing these narrow, often harmful ideals that contribute to so much suffering?
That's definitely something worth thinking about.